Hello everybody, here I want to explain a topic about pleural effusion. Okay, I got this PowerPoint from script.com and actually I haven't ever read this before. Usually I read some text or journal from the textbook Schwartz because I take general surgery and I usually read the Schwartz textbook. Sometimes I also discuss about some topic, illness or disease, and I take some reference from many things. One of them is script.com. And here is about the pleural effusion. We will discuss about the brief about pleural effusion and etiopathogenesis, the types of the pleural effusion, signs and symptoms that exhibited by the patient, and how to confirm the diagnosis and structural and functional impairments. Here is the introduction. We know that pleural effusion is a condition where the abnormal accumulation of the fluid between the parietal pleura and visceral pleura, and we call this as pleural effusion. The accumulation of pleural fluid is called empyema, so this is different, but we can still call this as a fluid, but the consistency of the fluid is different because the purulent fluid is a pus, or I mean the viscous, so and thick, so we can call that as empyema, thoracic empyema. Normally the pleural space contains a small amount of fluid and it is about 1.26 milliliter per kilograms, and this fluid allow the lungs to inflate and deflate with minimal friction, and a minimum of 500 milliliter of fluid is necessary for clinical detection of pleural effusion. Here's the pathology of the pleural effusion. We have discussed this before in previous slide. The pleural space is made up of a visceral layer and also a parietal layer. Here we can see this one. The blue line is parietal layer, and the inside of this one is visceral layer. So the pleural fluid or a pleural effusion is accumulation of the fluid inside of between these two layers, so it can make the lung cannot expand maximally due to the accumulation of the fluid here. The source of pleural fluid are the pulmonary capillaries or systematic capillaries, and there are lymphatics from parietal pleura, which drains excess fluids and maintains the normal pressure within. So how the mechanism what that make the pleural effusion. So there are two mechanisms, and the first one is excess pleural fluid formation and decreased pleural fluid clearance. The causes of the pleural effusion is usually caused by the excess pleural fluid accumulation and decreased pleural fluid clearance. Some factors or some mechanism behind the first factor is increased permeability or inflammation due to infection usually, and increased venous pressure, decreased in plasmic oncotic pressure, and also the last one is decrease in pleural pressure in cases of lung collapse. And the second mechanism is decreased pleural fluid clearance. So here we can see usually caused by the blockage of lymphatic stoma, mechanical compression on the lymphatic vessels, and increased venous pressure as the lymphatic vessels, but it won't be able to drain in the venous system. Limitation of the respiratory motion. The classification, I mean here it is the type of the pleural quality. It can be transuded or exuded. Now, the exuded usually is not clear, I mean the color, but in transuded it is clear, and yeah, maybe yellow clear or something, yeah, white transparent. But in exuded, due to there are a lot of plasma and rich in proteins, it will make the outlook of the exuded like something cloudy or dirt. So that usually caused by the plasma and proteins. Usually in exuded, it is caused by the inflammatory conditions like tuberculosis. It can also caused by the malignancy, pneumonia, pulmonary infarction, RA, pancreatitis, systemic lupus erythematosus, drug-induced effusion, and other condition. But in transuded, it's also caused by the congestive heart failure, cirrhosis of liver, nephrotic syndrome, severe malnutrition, hypothyroidism, constrictive pericarditis, and peritoneal dialysis. Then when we want to distinguish or difference the transuded one from the exuded one, we usually use the Leitch criteria. There are some measurement or calculation, so when we can differentiate between the transuded and exuded. The types of the pleural effusion is variative. Here it said that there are some types like iatrogenic, recurrent pleural effusion, bilateral pleural effusion, phantom tumor, milky effusion, hematothorax, purulent effusion, and acute pleural effusion. The symptoms that usually experienced by the patient is dyspnea or shortness of breath, and yeah, sometimes they also complain about the fever or dry cough, pleuritic, breathlessness, and another symptoms. Okay, it is the signs. We can do that observation or palpation to our patient. We also need to do the physical exam to make the diagnosis more clear, so we can do the precaution or auscultation. Here is the radiological investigation, and then I think this one is meniscus sign, or meniscus sign. So I think there is a possibility of the fluid collection on the right side of the thoracic, and a minimum of 200 of milliliters of fluid is required for detection in this view. So when we can see the picture of this chest x-ray, it usually minimum of 200 of milliliter to show the sign of like this. Okay, we can also use the ultrasound, and it can detect a minimal fluid collection of effusion. Okay, here is a thoracoscopy or fats and diagnostic thoracosynthesis. Okay, the management here, we have to motivate the patient to have enough rest and adequate nutrition, vitamins, and for another management that the patient have is thoracosynthesis, pleural tapping, a large effusion, and emphysema. Okay, I think that is enough. It is okay, thank you. Maybe that's enough for today. If you have some question, you can ask and you can type it in the comment section below. Thank you.